Welcome back, people, to Nexus. If you're joining us for the algorithm series, I would highly advise going and watching video 1, or else you're going to be incredibly lost. We're currently exploring this algorithm to assist in patient examination, and currently we're about a third of the way through it. If you just watched the first video, then let's dive back in. Let's say that you've already performed active range of motion and then determined that passive range of motion was not limited, or there's another route to get here actually, and that's if you performed active range of motion and it wasn't limited, but active range of motion alone was enough to produce pain. That would also lead you to the question of, well, what's it like if I just do it passively? The passive, after achieving full active range of motion, is not about the range per se, it's about how reactive this tissue is. And what does the range look like? Firstly, we want to know, is there pain? If there is pain, the follow-up question we're going to want to know is, what motion of passive range of motion actually produced it? Was it the same direction they experienced pain with active range of motion? Was it the opposite direction, or was it just painful in all the directions? This is the idea of Cyriac's model, after the orthopedic physician James Cyriac. The idea tries to utilize common sense about tissues and their nature. If you have a tissue that is painful in opposite directions for active range of motion and passive range of motion, that means that it's a tissue that actively in one direction it hurts, and then when you fully lengthen it, it hurts passively. And this really points towards contractile tissue, muscles and tendons. It would make sense that when the muscle is actively producing a force, and then when you fully lengthen that muscle out, that it would elicit pain. If you have pain in the same direction for active and passive range of motion, this sounds more non-contractile or ligamental, capsular, etc. It's a nice simple model that can help out a lot when you're performing manual diagnostic tests. Either of these scenarios are going to lead you to the next question of, well, how acute is the tissue that we're dealing with? How acute along in the healing process? If it's highly acute, then we probably want to do more tissue regenerative therapies, exercise dose for sort of optimal stimulation of the cells, or some sort of cell swelling, low-grade protocol of blood flow restrictions. But if it's not acute, then the idea is we're probably dealing with a reduced stress-strain tolerance, and we can do more tissue tolerance training for this. Both have the goal of improving the tissue tolerance, and then we further assess active range of motion, leading hopefully down a different path now to deal with different impairments. What happens if we have the other scenario of it being painful in all directions? Well, this could be an inflammatory situation, either acute or chronic, or this could be a sensitization scenario, either peripheral or central. At this point, you'd probably test for either using signs for inflammation or using things like 2-point discrimination, thumbnail test for a sympathetic response, or left-right disassociation awareness, things like that. As an aside, Adrian Lowe gave a great talk at AOMT a few years back and discussed the cortical remapping that occurs with sensitized or chronic pain patients, and how their inability to perform motor patterns might be that the brain has remapped that area and why they might not be able to disassociate well. So he discussed drawing out a grid on someone and getting them to tell you what quadrant or number you're touching so that you're trying to remap that pathway. Really cool stuff. Another question that comes up from the passive range of motion testing is, how did it compare to active range of motion? We know that neither was limited if we're in this area of the algorithm, but was the passive range of motion excessive? If it was excessive, then we need to determine if active range of motion would change if we change the position of the body or the region to reduce the load. Now, I skipped a couple paths. For instance, passive range of motion if it was not painful, and passive range of motion was not excessive. And the reason is that both of these are going to go to the same place. And it's also the same place we would go if we did tested active range of motion, and by changing the position, the patient was now fully able to achieve it. And you guessed it, it's resisted testing. But let's further explore what happens if passive range of motion is excessive and active range of motion does not change dependent on the position of the body. Because the question here now brings up the idea of, is this impaired timing, a pattern, or a balance of muscles or balance issue? You can utilize things like EMG, palpation, or you can try to stimulate activity through simple cueing to see if there's a change. If you watch the manual therapy lesion video, this is highlighting again my favorite concept of afferent input. If you find that they can grasp the concepts of what you're telling them to achieve, and they don't have any actual impaired learning or to the timing or planning, then you can just work on normalizing their patterns, their bigger movement patterns. If you did determine that they had issues with these things, then you can try one of two options. You can either use inhibitory manual therapy, or you can try facilitatory manual therapy. Now, these don't have to be manual, but the idea here is that odds are you will have to either down-train guarded patterns through inhibition first, and then up-train inhibited patterns through facilitation next. Guarded can be done through vascularization, 60% of 1 rep max, and up-training can be done through either isometrics, 2 to 3 sets at 80 to 150% 1 rep max, or eccentrics, 80 to 85% 1 rep max. Once we have the muscles independently doing what we need them to do, then we can determine if the full movement is incoordinated or inefficient. If no, then we're going to move all the way up to resisted testing, but if yes, then we probably want to try and coordinate that pattern. Now, if you can help coordinate a pattern with external cueing, go straight to that route. It's a much more successful technique, and there's better carryover for learning. However, there are certain scenarios where you might have to utilize internal cueing first and try to get external as quickly as possible later. When you achieve this, then it's also time to move up to resisted testing. So we now have about 6 different pathways at this point asking what's up with resisted testing for this area, and we'll find out next time. If you enjoyed this video, please hit the subscribe button and the notification bell, and thanks for joining us.